today's topic. This is the Tuesday trivia. Basically, we have this every month. It is a office practice guideline kind of academic sessions done by the Pediatric Pulmonology chapter of the West Bengal Academy of Pediatrics. So in this, we usually cater to some common respiratory disorders in pediatrics, and we usually do it in the form that it is very relevant to the office practice of general pediatricians. So today's topic is on aspiration disorders. And for this, we have four eminent speakers. And we are very pleased to welcome Dr. Shilpa Hazare. She is MD DCH DNB, and she has an IAP certificate course in pediatric pulmonology. She is the chief pediatric intensivist, pulmonologist, and bronchoscopist at Getwell Hospital and Research Institute. And she is practicing intensive care since the last 20 years and flexible bronchoscopy in neonatology and pediatrics for the last 5 years, for more than 5 years. She's the current chairperson of the PICC in Nagpur. She was the former vice president and EB of IIP Nagpur, and she is the national trainer for ATM, RTI, GEM, war, cuff modules, and under 5 Vs, NTEP. And she has many publications in national journals. She's the former associate professor of JNMC Savangi and former lecturer at IGMC Nagpur and JNMC Savangi. She's also the member of Central IP NNF Respiratory Chapter and European Respiratory Society. A very warm welcome to you, ma'am.
Thank you, Dr. Amita, for such an elaborate introduction. Thanks a lot. And thank you also for inviting me as a panelist for this discussion.
Yeah. So our next speaker is Dr. Pallab Chatterjee, and he is, I think, very well known in West Bengal. Doesn't need a special introduction, but nevertheless, I would just give a brief introduction for Pallab, who is our go-to person for bronchoscopy. A short introduction, but he is also MBBS, DCH, MD Pediatrics, DNB, and FIAP. He has the European Diplomate of Pediatric Respiratory Medicine, Chairperson, Computer and Medical Informatics Chapter of IIP 2122. He's the Secretary of West Bengal Academy of Pediatrics from 2018 and 19. And he's the member of the EB Executive Committee of IIP in 2020, Scientific Chairperson of the West Bengal Chapter of Pediatric Pulmonology, and one of the founder members of the National Respiratory Chapter of Pediatric Pulmonology. He has authored chapters in various textbooks like the PG Textbook of Pediatrics, IIP Textbook of Pediatrics, and IIP Textbook of Tropical Pediatrics. So, Pallab, a very warm welcome to you too. And Dr. Mohan Ghantasala next. We are also privileged to have him because he's a specialized speech and language pathologist, and I will just give his introduction. He is MS CCC speech language pathologist and a senior consultant at Aster Prime Hyderabad, and he was the 1988 alumnus of IISH Mysore and ASHA. He holds the ASHA Fellowship in New York, 1999, and ASHA US Board Certified CCC and Speech Language as Pathologist in 2003. Last but not the least, our very own Dr. Gautam Rai, who is a pediatric gastroenterologist at, he is the, just one second. He's the assistant professor of pediatric gastroenterology, School of Digestive and Liver Diseases, IPGMR, Kolkata, and he is a very dear friend also. So welcome you all to today's session, and I will not waste any more time and let Dr. Shilpa take over the session from now
on. Thank you. I'm just sharing my screen.
So if you do not know, Dr. Shilpa's Getwell Hospital is a huge hospital. So I've been there, and it's a wonderful place, and she's actually the owner of the hospital. So she's one of the owners of the hospital, along with her husband, who's a pediatric surgeon. So it's a fantastic place with a lot of facilities that are there, and it's great to work there. So privileged to have Shilpa here. She's
Thank you,
got
sir.
a huge experience. So she's going to first start off with introduction to what we are planning to discuss today, and thereafter we will have a few uh, case presentations. So she'll give a short introduction on aspiration syndromes.
Thank you, sir. So initially, I'll be telling little a keynote address, theoretical keynote address on aspiration syndromes, and then later on we'll have very short cases actually, but the discussion should be more on those cases. Can you see the screen, sir?
Yes, yes, yes. It's opening, but
Huh.
yeah.
I can't see anything just now.
Saying not responding. So maybe you have to.
Hello, Aditya.
Can you see, sir?
Yes, 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 yes. Yes,
Okay.
we can hear.
Okay.
See.
So just okay. So basically, we all know that what is aspiration. Aspiration is basically inhalation of anything into the lower airways. So whether it is oropharyngeal contents or gastric contents, if they are going into lower airways, that is called as aspiration. And pneumonia, aspiration pneumonia is a complication of pulmonary aspiration. There is an entity which is called as chronic pulmonary aspiration syndrome, and that is basically entry of food material or gastric contents and or saliva into the subglottic airways in a manner sufficient to induce chronic or recurrent respiratory symptoms. So this is basically there is a recurrent aspiration which is going on for a long time, which induces recurrent respiratory symptoms. Aspiration pneumonia is an important entity, and it is a cause of serious morbidity and mortality, especially in children who have chronic medical conditions or neurological issues. The lobes which are involved as far as lungs are concerned, like if it's an infant who is mostly so less than 2 year old, or an infant who is mostly in the supine position, the segments which will be affected by aspirations would be posterior segments of upper lobe and apical segment of lower lobes. Whereas if it's an older child, and if that child is aspirating, especially if he's up in upright position, standing or sitting position, then the involvement is basal segments of the lower lobe. So this is very important to know that where when we see the x-ray, if these lobes are involved, then we have to think of aspiration. Now, what is the mechanism of aspiration? So the first thing is swallowing dysfunction. So basically, swallowing dysfunction is more common in neurologically impaired children. That is because the mechanism which is neurologically controlled, that is having a problem, and that is why. And there are different phases of swallowing processes which are voluntary as well as involuntary, and there needs to be a complex coordination among all these actions. And the children who are neurologically impaired, there will be a problem in this coordination, which results ultimately in aspiration while swallowing the things only. The second thing is salivary aspiration. So salivary aspiration is basically, it's a chronic kind of salivary aspiration, and rather than swallowing dysfunction, there is an abnormal laryngeal sensation. So there is no excessive production of saliva in them, but there is an abnormal laryngeal secretion as sensations, and that allows the saliva to go in. The cough is not there, and that is why the chronic salivary aspiration does occur, and that doesn't produce much symptoms also, because the quantity is not very significant, and it goes on for a long period, a chronic thing, and then that is why it is recognized very late when the underlying damage is significant. And the third mechanism is basically gastroesophageal reflux, which is quite common, especially in healthy infants and children. So, younger children, gastroesophageal reflux is a physiological phenomena. But if it is producing symptoms, or if it is creating problems in children, then it will be labeled as gastroesophageal reflux disease, which is a pathological phenomena, and there is quite a few times it is associated with cardiopulmonary arrest also. So in babies, in some babies where it is a pathological phenomena, we have to take this seriously. So who are these high risk children where recurrent aspirations or significant aspirations are likely? So most common is neurological impairment, which is commonest is cerebral palsy. So in them, there is a risk of they are at high risk of aspiration. There are quite a few metabolic disorders. Again, in metabolic disorders also, along with other things, there will be a lot of times neurological impairment would be there. Certain genetic disorders like Pierre-Robin syndrome, where the mandible is hypoplastic, the tongue is very large, tongue falls back, and that is the reason they are prone for aspirations. Pierre-Robin syndrome will also have cleft palate, that also produces swallowing dysfunction. So there are multiple mechanisms in Pierre-Robin syndrome. The Down syndrome, they are hypotonic, so there will be hypotonia in all the smooth muscles, in the pharyngeal muscles, everywhere. So they are again at risk of aspirations. Myopathies and muscular dystrophies, then neuromuscular diseases like spinal muscular atrophy. All premature babies, they are at a risk of aspirations, because basically everything is in a problem in premature baby. They have, their tone is also less, then the functions like swallowing function is not very well developed, or the GER is gastroesophageal reflux is also significantly more in premature babies, so they are at risk. Chronic lung diseases like cystic fibrosis, there also they are at high risk. Every child with any kind of respiratory distress, they are at risk. Recurrent pneumonia children, they are at risk. And okay, yes, and I think these are more of a symptoms only. So basically, what are the types of aspiration pneumonia? So the most common is that after a child has aspirated, they will develop chemical pneumonia. So chemical pneumonia basically occurs if there is a large volume. So it has to be more than 4 ml per kg of sterile acidic content, which is going into the airways and lung, then only it will have chemical pneumonia, and that represents an inflammatory reaction to gastric acid rather than a bacterial infection. So there is no bacterial infection as such, so it's a inflammation induced by gastric acid, so that is chemical pneumonia. The other possibility is primary bacterial pneumonia. So primary bacterial pneumonia, that aspiration is the child has aspirated, the upper airway secretion, saliva, or any other upper airway secretion, where if suppose there was a significantly infected tonsils, or if there is a pharyngitis and there was a significant bacterial load in that aspirate, then they may develop primary bacterial pneumonia also. And by and large, this will be more right side will be more commonly affected than left, and they will by and large involving lower airways rather than upper airways. So basically, even primary bacterial, though less likely, the more common is chemical pneumonia. Now, complications of primary bacterial aspiration pneumonia, we all know they are lung abscess, empyema, bronchiectasis, pleural fistula, and by and large, if it's a primary bacterial pneumonia, the aerobic organisms will be the main causes. Again, this is more common. So chemical pneumonia is the most common, and the second most common is secondary bacterial infection of chemical pneumonia. So 25% of the chemical pneumonia patients, they initially improve and then later on again deteriorate because of superimposed bacterial infections, and the chest x-ray shows worsening of initial infiltrates or development of new ones. So many times when you see radiologically, immediately after aspiration, you may find a normal X-ray chest, but later on, after 24 to 48 hours, they may show infiltrates, because chemical pneumonia, there won't be before 24 hours, the X-ray test may be normal and there won't be any significant radiological findings there. So by and large, if there is an aspiration, you should be doing X-ray test at least after 24 hours. So what is a clinical course? Basically, in all children who are aspirating, almost 60% of the patients condition improves and the lung infiltrates resolve in 2 to 4 days. But in 15% of the patients, the condition deteriorates very rapidly within 24 to 36 hours, and the respiratory distress goes on increasing, and they ultimately progress to hypoxic respiratory failure, and they may land up in ARDS and on ventilation and prolonged ventilation. But in other 25% of the patients, the condition may improve initially, but later on it may worsen and secondary bacterial infection may set in these children. The death rate in this patient is almost 3 times higher than in patients with uncomplicated pneumonia. So aspiration pneumonia, one should not be taking it lightly. So what are the causative organisms? So we have aerobes as well as anaerobes. So basically aerobes are when the upper airways, like if the gastric contents are not there, so if there is a swallowing dysfunction only, or if the pharyngeal from pharynx only, if the child has aspirated, the aerobes would be more likely, like in normal children or neurologically impaired children who are having swallowing dysfunction, or those on ventilation who are aspirating their saliva besides the endotracheal tube, they will be developing these aerobic secondary bacterial infection as aspiration pneumonia. So they can be alpha hemolytic streptococci, or it could be E. coli, Klebsiella, or Staph aureus, or Pseudomonas. So these are the common organism. And anaerobes would be likely if there is a food content, like if the child has aspirated the food which from stomach and which has gone into the airway. So anaerobes like microaerophilic gram-positive cocci, or bacteroid groups, or fusobacteria, or peptostreptococci, and Prevotella. So these are the possible organisms. So what investigations one can do for diagnosing? So basically, we can do a complete blood count, but that would be normal in initial stages when there is a chemical pneumonia. So complete blood count will be altered later on if there is a secondary bacterial infection, or if it's a primary bacterial pneumonia. Even though it's aspiration, so there would be leukocytosis. If there is a bacterial superimposed bacterial infection. ESR and CRP may be elevated from the beginning, but by and large after 24 hours, because they will just show they are inflammatory markers, so they could be elevated even in chemical pneumonia and not necessarily in secondary bacterial infection. Procalcitonin, again, it's a marker for bacterial infection. So initially procalcitonin may be normal, but if there is a secondary superimposed bacterial infection, then it would be abnormal. X-ray chest, I already told you that findings may not be there, even if child is looking in respiratory distress, needing oxygen, but the chest X-ray may be normal if you do it immediately, but it would be abnormal later on after 24 to 48 hours. So one should be doing after 24 hours. ABG, if the child is having significant respiratory distress and if the child is needing oxygen, then we need to do a arterial blood gases to know how significant oxygen gradient is increased. Like if there is a significantly increased oxygen gradient, then you have to be prepared that this child may deteriorate and may need ventilation. So child who is having respiratory distress, one need to monitor by ABG, doing ABG of that child. Bronchoscopy, by and large in acute stage, when somebody is aspirating for the first time, it is not required, but especially if there is a recurrent history, recurrent cough or recurrent aspiration pneumonia, bronchoscopy becomes mandatory, because that BAL, which is sent for multiple tests, may give a lot of information to you how to go ahead with that child. And finally, CT scan chest. Again, CT scan chest would be required in those chronic aspiration cases or recurrent aspiration cases. So this is a X-ray which is seen. This is classically a dense haziness in the right upper lobe, which is the most common, like a hallmark. If this kind of X-ray we see, we know that it's aspiration. So this is that type of X-ray, but one can get even like this X-ray, like both the lower lobes are involved. So this is probably, this child is probably was in supine position when he aspirated, and this child probably was in a upright position when he aspirated. So both kind of X-rays you can have. Is there any role of antibiotic in aspiration pneumonia? Again, now there is it's very controversial thing whether we should be giving an empiric antibiotic therapy or not, because many times there are two school of thought. Some may say that it will otherwise land up in secondary bacterial infection, so one should be giving empiric antibiotic therapy. Otherwise, the second school of thought says that it just escalates the treatment cost and poses the risk of antibiotic resistance. So it's really difficult, but antibiotic, and they basically the antibiotics do not seem to alter the clinical outcome, including the radiographic resolution, neither duration of hospitalization or death rate, nor they influence the subsequent development of infection. So in most of the cases, actually, empiric antibiotic therapy is not required unless somebody has a life-threatening aspiration, which is acute and is in significant distress. So in that case, one may justify. Otherwise, there is no role of antibiotics in clear-cut cases of chemical pneumonitis. Now, to detect secondary bacterial infection early is the challenging thing, and it is required so that the patient, because the mortality is 3 times than the normal pneumonia patient, so we need to be very alert to detect secondary bacterial infection early, and for that respiratory status should be monitored, because if it's a chemical pneumonia, it should improve in 72 hours or at least 3 to 4 days. But if the status is not improving or if they are deteriorating, then in that case, there is a suspicion that there is secondary bacterial infection, or if initially, or if they start getting high grade fever clinically, the respiratory distress is also deteriorating, then that becomes more likely. In less clear-cut cases, it becomes prudent to start antibiotics empirically after obtaining lower respiratory tract secretions for stains, cultures, and then to reassess whether within 48 to 72 hours. Antibiotics, if we have started, if the child had significant respiratory distress, and even though we knew that probably we are not very crystal clear that it's a chemical pneumonia, or if, is there any bacterial infection also, and we have started antibiotic in that child, but then it should be discontinued if the patient shows rapid clinical as well as radiological recovery, and if the cultures are negative, it should be rapidly stopped, or there should be an antibiotic stewardship. So those whose condition does not improve or whose cultures come as positive, then they need a full course of antibiotic therapy. So for primary bacterial aspiration pneumonia, or if it's a nosocomial pneumonia, the course of antibiotic is required, and choice of antibiotic for primary bacterial aspiration pneumonia is clindamycin, along with beta-lactam penicillins, and plus minus quinolones. So quinolones presently now we do not recommend much because we want to keep it preserved for TB. So basically clindamycin and beta-lactam penicillins. Metronidazole should not be used alone for considering that if it's aspiration, it's anaerobe only. So it should not be used alone. It has to be combined with other antibiotics, or if in case if you are using an antibiotic which has anaerobic cover also, it need not be used, because alone using metronidazole has a high clinical failure rate. For nosocomial aspiration pneumonia, broad spectrum coverage is needed initially, but then after culture we need to decide whether we need to escalate or de-escalate. So basically, before the cultures, we are the recommendation is you give beta-lactam penicillins with extended gram-negative coverage, or you can use carbapenems plus either vancomycin or clindamycin. So both will have anaerobic cover, vancomycin as well as clindamycin. So you need not use metronidazole if you are using vancomycin or clindamycin. Again, one word of caution is, whenever you are using clindamycin, many times the D-test has to be done by a microbiologist, because if that is, it may have a significant in vivo resistance also if the D-test is positive. So that has to be done. Duration of antibiotic therapy for uncomplicated cases, it is 7 to 10 days, but for complicated cases, it could be 2 to 4 weeks or longer than that also, or until there is a clinical or radiological improvement is seen, along with drainage of abscess or empyema if it is there. Otherwise, for uncomplicated cases, it is 7 to 10 days. For nosocomial pneumonia, it could be 2 to 3 weeks, depending upon the clinical recovery. How do we prevent aspiration? Now, this is the most important thing, I think. So we, especially in those high-risk children where there is a possibility of chronic or recurrent aspiration, one need to elevate the head, and especially while feeding. Lateral positioning, especially left lateral positioning, for approximately an hour after feeding. Good oral hygiene has to be maintained, especially this is important in neurologically impaired children. Thickening of feed, this is as per the recent guidelines, thickening of the feeds is the most important point, and present actually the latest recommendations. In fact, the continuous elevation of head is not being recommended now. In fact, only thickening feed is indicated, but if it's an older child with neurological impairment, one can do elevation of the head, and but younger infants, that should be avoided because of the risk of SIDS actually. And those children with neurological impairment, one could also think of percutaneous endoscopic gastrostomy tubes, which is PEG in these children, because that would significantly prevent the risk of aspiration. What are the long-term sequelae? So major sequelae is
Shilpa, we have to wind up now. We have to go
Yes,
for
sir.
the cases.
Finishing
Yes.
only. So major sequelae is restrictive lung disease or obstructive lung disease or bronchiectasis, and minor would be chronic bronchitis and bronchial asthma. The lentil aspiration is one entity which is very important in India, and it is the important cause of hypersensitivity pneumonia in infants of weaning age with forced feeding practices. And there is a big article written by Dr. S.K. Kabra sir, and a big study also done by him for this, which one can go and search on YouTube. The common symptoms with lentil aspiration are like chronic cough, shortness of breath, fever, vomiting, and wheezing. There could be fine crackles, but there are by and large no clubbing. Radiologically, they show nodular opacities and consolidation. BAL by and large shows increased neutrophils, and diagnosis of lentil aspiration is by and large by elevated IgG, which is specific to lentil antigen. And there is a rapid remission seen with systemic steroids as far as lentil aspiration is concerned. So the first case is 7 days old female baby. There is a history of choking with feeding. The baby was admitted with aspiration pneumonia with oxygen requirement and significant respiratory distress, and the child was given all the necessary treatment for that, for which I will not go in detail, and this child was stable on RT feeds. These are the x-rays of that child. So these are the x-rays at two different times. Like the first x-ray is the left one, and the second x-ray is, and you can see that the first x-ray is better than the second, whereas the clinical recovery, the child was more bad with the first x-ray and less bad with the second x-ray. So roughly 48 hours apart, these are the two x-rays. So any comments, sir?
Yeah, so I would say that what is happening is now it is getting organized, and maybe this would the chemical pneumonitis is probably converting into a secondary bacterial infection. So that is what is happening in this child. But other than that, why this child? You mean to say that the child had improved by
Yes,
by
sir.
the time you had
Yes,
the
sir.
second
Yes,
X-ray?
sir. Yes, sir. Clinically,
Yeah. So
child had improved. It is just because the aspiration
so
becomes more prominent later on.
over a period of time,
Yes,
yes. So
yes,
the radiological evidence comes up later. So
yes,
that is how this thing is happening.
yes, sir. Sir, any other comment? Like, what do you think on this history? Like, anyone can have a comment. That what do you think this child must be having?
Yeah, so a 7-day-old female baby, if this child is choking with feeding and admitted with aspiration pneumonia, then I would rather think that either there is a swallowing issue that is happening in this child, or if this child might have a H-type fistula. So one of the two will be very high up on my list.
Yes, sir. Absolutely correct. So let me show you this child's bronchoscopy. So I did a flexible bronchoscopy in this child, and if you can see, I thought that this child has this was initially I thought that this is a H fistula, but actually this was not the H fistula because it was not opening. And then I went ahead, and there was a big fistula there, which was almost in the lower 1/3 of. Can you see a big fistula?
Yes, a huge fistula is there.
Yeah,
Right.
so this was a huge fistula, and that was the reason child was having significant bad X-ray, like infiltrates in both the lung fields were there, and significant respiratory distress was there. So this is a still image which is showing clear-cut H fistula. So the final diagnosis was H fistula with aspiration. The child was given IV fluids, IV oxygen, and IV antibiotics, as this child was in significant respiratory distress and was having and the baby was neonate also. So before, once the child had improved, and we knew that the child has H fistula, after that the antibiotics were stopped also, and this child was, the fistula was surgically repaired and child was fine. So let's go to second case. Again, this case is a 4-month-old female baby admitted with severe respiratory distress. There was history of cough off and on, and there was history of vomitings also. There was failure to thrive. Heart rate was 160 per minute, so child was tachycardic, child was tachypneic also. Respiratory rate was 55 per minute, and saturations were just 80% on room air. There were bilateral crepitations present, and the crepitations were more on the right than left. Some spasticity was there. There was leukocytosis with increased polymorph, and the X-ray chest was this. This was the same X-ray which I used in the theory also. So there was a right upper lobe consolidation. There was a history in this child that at 2 months of age also this child was admitted in some hospital with gasping condition, and at that time also child had pneumonia on the right side, and there was history of cough, cold, fever, vomitings at that time also, and there was a history of seizure at that time as child was admitted in gasping condition. 2D echo was normal. This child was discharged at 2 months with the diagnosis of severe GERD, and there was no other further workup was not done, and child was discharged on anticonvulsants and anti-GER therapy. So what is in this child, basically the red flag was this child had near miss SIDS. So very commonly what we do is that we consider that the child has GERD, and we start anti-GER treatment to babies, and we don't investigate further. So, but always look for these red flags, and if these red flags are there, I think we should be investigating further. Sir, any comment on this case?
Before you at 4 months, if this child has got a little bit of spasticity and this child has got a right upper lobe consolidation, then I would rather bet on swallowing issues that this child might be having. Aspiration is definitely there, and it also could be GER, but then yes, we have to rule out both and then decide.
Absolutely.
We can take the
absolutely,
help of
sir.
our gastroenterologist here, Dr.
Yes,
Gautam,
yes.
that at 4 months, like what do you do to actually clamp your diagnosis as either this is a, GER or is this a swallowing issue?
So
Yeah.
do you recommend, if we get such cases, do you recommend further investigations?
Yeah, in this case, we need further investigations because the GER, the common garden variety of GER that we see, which all of us know, they are happy spitters and
Yes,
they don't need any investigations.
yes, yes.
So, but we should, I mean, alarm features, what you mentioned in your lecture, alarm features that should prompt further investigation is maybe, I mean, presence of forceful vomiting, or as you said, choking, gagging, coughing point feeds, if there is failure to thrive. Okay, so lethargy, etc. If there are neurological symptoms, then it prompts further investigation, obviously. So this child has alarm features, we need to investigate.
So let me tell you what we did. So what we noticed, one thing in this child was this child's cry was not very good, and that we thought that probably there is something. So we did bronchoscopy of this child, and there was a vocal cord palsy there. So I'll just stop because further everything is normal. So there was a unilateral vocal cord palsy in this child, and that was a reason for recurrent aspiration in this child. So probably there was rather than swallowing dysfunction because of the vocal cord palsy, this child was aspirating, and the spasticity, probably the episode which occurred at 2 months of age, when the child was admitted in gasping condition. So probably that hypoxia lasted for a significant time, and because of that, so the diagnosis was congenital vocal cord palsy. So what we did, we just gave NG feeds to this child. We taught the parents how to give NG feeds, and this child was given NG feeds for almost 6 to 8 months. Anti-GR therapy was continued, anticonvulsants were continued, and physiotherapy and early intervention clinic was advised to them. This child is a big child now and is almost near normal. So because the physiotherapy, there is, as far as mental status is concerned, she's quite okay, but there is minimal spasticity there. But the smile tells you that she's not all that bad. Like, but so for that, like I feel that one need to look for red flag signs in every child, and if they are there, then we need to be
Dr.
investigating
Gautam,
them.
supposing if we have such a child, would you straight away recommend a PEG in this child, or would you continue to give NG feeding for say 8 months, 6 to 8 months?
If a PEG is available, then I think PEG is a better, safer option.
Yeah.
Yes, because
So
once
what-
you put in a NG feed for 8 months, it is a bit risky because it again can increase the GER, and again maintaining a NG at home might be a bit tricky. So the parents have to be educated and taught, and they should know how to check the position of the tube and all that is there. So
Yes,
having
sir.
put in a PEG is much safer. So
Yes, sir.
if a child is requiring so long, I think it's better to go for a PEG before we go for
Absolutely.
such a long.
Absolutely true, sir. But as far as this child was concerned, the relatives were not at
No, it's
all
fine.
ready.
It's okay. No,
And
I'm
that
just saying,
was
I'm
the
just
reason.
theoretically
Yes.
so we should be clear in our mind that we should tell the parents to like go for a PEG before we,
Yes.
Okay, shall we go to the next case?
Yes, sir. This is the last case. 2-year-old girl child weighing 8.5 kg. So there is a failure to thrive. She complained of pain in epigastric region, poor appetite, significantly poor appetite, and occasional vomiting episodes were there. This child, I have not written, did not have significant respiratory complaints, but mother always complained that she gets cough, but then she used to go to some nearby pediatricians and take some medications for 4-5 days, and she used to be all right. So cough is not a very significant complaint for that child, but she keeps getting milder episodes of cough off and on, which doesn't require a significant grade treatment. But the biggest problem was pain in epigastric region and poor appetite and failure to thrive, not gaining weight. So her GR study was done, and that showed a significant reflux, which can you see the arrow which I am showing? Is arrow
Yes, yes.
seen? Yeah, okay. So basically here the barium was given. Now the barium is in the stomach, and now in this film we can see that the barium is coming up. Now it has again gone up, and here again it is going significantly up. So here again, so basically this showed a significant reflux in this child. So it was almost grade 3 to grade 4 reflux in that child. And she also had a this is a reverse film, that is why the black the esophagus is seen as black, but the esophagus is dilated and tortuous. So what is the meaning of dilated? If you see this kind of esophagus in the GR study, that means that the reflux is going on for a very long time, and that is the reason the esophagus is getting dilated and tortuous. So that just tells you that there is a significant reflux which is going on for a long time. So this was there.
Dr. Gautam,
Yeah.
what I would like to know from you is the GR the causing the dilated and tortuous esophagus, or is it the dilated and tortuous esophagus which is leading to GR?
So it's a higher probability that it is some anatomical abnormality which is causing the reflux, because his child is what, 2 years old, no? Yeah.
But
Yeah.
it's very long standing X3, almost.
Yeah. So what
Or-
typically, as a consequence of untreated GERD, what happens is a stricture. So it is unlikely that, this dilated tortuous. More importantly, I would just, I want to make a few comments. Should I do it now?
Yes,
or
yes, yes,
Yeah,
please,
yeah,
please,
yeah,
yes.
bilkul.
Yeah. So, GERD, like we suspect it definitely. Clinics, we have to suspect it clinically. But when we want to prove it, there is no single gold standard test to diagnose GERD. And all of us throughout the years, we have also done it. We use barium to diagnose GERD, which is...
Yeah, Gautam, shall I come to this in my case? So I think,
Okay,
Shilpa,
okay.
you've
Yeah, yeah.
finished
Yes.
this thing, no?
Yes, sir.
So
Yes,
can
sir.
you stop sharing?
Yes, sir.
Oh, thank you very much.
Thank you, sir.
She needs a big hand for fantastic and excellent cases.
Thank you, sir.
And in the meantime, I'll share 2 of my cases very fast. So this was a child, 2-month-old, history of choking since birth and associated respiratory distress. And this was a gastrographin study that was done now. And that again showed a lot of reflux. And a similar study again done a long time back, which was a barium meal, which was done another kid a few years back. So previously we used to do a barium study. Now they're doing a gastrographin study.
Gastrographin only,
And
sir.
yeah.
What
And,
I meant barium meaning that only. Even in our
Okay.
case, it was that.
No. Even here, no, we used to do a barium previously. And again, there's a milk scan. Now I throw the thing open to Gautam that what is the gold standard? What do you do? So what do we as pediatricians will recommend and do to diagnose and stamp this child as having a GERD?
Okay, so when it comes to infants, I think initially what we can do is there are some questionnaires which are available. The modified Orenstein's infant questionnaire. So that is, there are various, we can get it, we can download it. So that helps us diagnose GER versus GERD. So there are various scores and all. But in an older child, post-infancy, when you are suspecting esophagitis, heartburn, etc., then the test of choice, the investigation should be clinically tailored. So when we are suspecting esophagitis, heartburn, etc., then what we need is an endoscopy. When we are suspecting, when the clinical situation is that of a dysphagia, and it might suggest an anatomical abnormality, that time a barium series is indicated. But if we are considering a diagnosis of GERD in a patient who has extraesophageal symptoms, such as maybe an asthma or an aspiration pneumonia, and we have ruled out, obviously, the more important, more common causes, it is not directly fitting into an asthma, then we need other sophisticated investigations such as pH impedance study and all. So let us not go into that. The basic thing is, in infancy, we can use charts. Post-infancy, our diagnostic test should be tailored to the clinical scenario. Using barium upfront for diagnosing GERD may not help in all cases because the sensitivity is at best 60-70%. In this infant, if we have a pediatric surgeon on board, maybe. Do we have anybody?
No, we don't.
Okay. So I leave it to the others.
Okay. And milk scan, do you really do?
No,
We don't.
No, we don't do. And to tell you the truth, we get very few referrals for infants. In our gastroenterology department, most of our referrals are for older children. So I think infants, early infancy, it is mainly handled by neonatologists and pediatricians.
Okay. And this was another test that some of us tend to do. This is called the feed study. So when you put the endoscope there and you feed the child, and you see what happens to the milk, and you can actually see that the child is aspirating the milk straight down through the there you see the child is aspirating. So you see that the milk going in. So this is the feed study. Okay. So that is the milk that is going in. Okay. So this another child, 1 month old female, meconium stent did not cry at birth, required intubation and ventilation, and all that was started on CPAP. There was copious secretions that was there and persistent feeding issues. Their child was on NG feeds, and then again respiratory. This child was discharged with NG feeds. So that's what I was telling, that it's if you have to discharge a child on NG feeds, then you have to be very, very careful. So this child went home. 3 days back, this child again got back to the ER with severe respiratory distress, and this child was put on HFNC, then gradually weaned off, but continued to require minimal oxygen. And this child is still now on, has been started on OG feeds. There were some dysmorphic features, and we plan to do a bronchoscopy of the airways. And what was seen was there was a lot of secretions that this child was not able to swallow. So this is the we also had thought of doing a fees, but there is no point in doing a fees in this study, because look at the secretions that is pooled around the larynx. Now, this people are the doctors treating this child are still struggling to how to feed this child, and this is something that we also very commonly face in this in such patients, that there was a lot of secretions and it's difficult for us to feed these children. So I would now ask Dr. Mohan, that how do you manage such children? How do you organize, like how do you feed these children, and what do you do? So what is the feeding technique? What is the magic that we can do to help the poor parents?
I think this case that you are telling about, where there is a lot of secretion in the airway, and it's very clear case of child who is not able to swallow. I think when we put a tube and send them home, we are not able to train the parents about the situation, and they may feed with the tube also sometime. And even if they are not feeding directly, any feeding trial that we are doing is very important. How to feed the child, and as early as possible remove the tube is the big issue there. So how we position, what type of viscosity, what volume, and what foods we are giving to the child, how the child is tolerating. This is a big plan of how to get the sufficient food intake, and how we can position and let the child happily without fear feed and all that. So that's a big transitional plan once you go for a tubing kind of a scenario.
So suppose this child, what would you do? I refer this child to you.
I would work on the variables of volume, viscosity, and see that the food is safely swallowed. Only we can ensure by observation that the food is being safely swallowed. We cannot let anybody feed and then let them come back to ER.
Okay. So is there any speech and language where you these the salt therapies, like you do some maneuvers in the mouth?
This is what is swallow therapy. What you are asking for is the proper swallow therapy. Yes. And there is no speech language issue there. I'm sure they have some speech language issues concomitant.
Correct. So swallow, what do you, how will we, like, how do you
see the kind of
audience?
Let us say we are using a certain spoon or certain volume and certain thickness of the food, certain viscosity of the food. We prepare the foods in a certain way. These are the things that will minimize the aspiration. We can't just say feeding trials can be done randomly. So we are trying to figure what type of food can be tolerated and how the child is behaving when the child is feeding. And then we say, okay, this is how it's working. These are the feeding trials that are the challenge to us.
Okay. So would you advocate if it's you want to take out the NG tube, isn't it?
Yes, yes, that is that.
So if you take out the NG tube, would you advocate putting in a peg till the child is actually
Definitely. As you have told in the other case, PEG is always a better preference, you said in that case. I'm sure till we figure out a better, like a month's feeding trials or a week's feeding trials and come to a nice way of figuring out what to do with the child in terms of oral feeds, with or without a tube and all that, maybe PEG can be kept for a while.
Dr. Gautam, your inputs, like anything that we can do to help these parents, the distraught parents who just cannot, and it's going on, and the child is in the NICU and nobody knows what to do. The child cannot swallow.
Yeah, I think we will do a PEG so that the nutrition is maintained, and get a pediatric surgeon into the foray. Maybe
What is the age of this case, sir?
etc. If it resolves, good. If it doesn't, then
This child was around 1 month.
Yeah, so it's a very challenging age, and how many options do we have? Like if we say, let's
So that's
say
what.
we
So
have
this
some-
challenge, what we want to know from you is how do you manage such? This is an NICU scenario. So how do you manage such
I
swallowing
am
issues in
thinking
the
that
NICU?
viscosity of the food is a big variable here, and volume is a big variable in addition to the posturing.
Okay.
Even PEG
And-
becomes very difficult at this age because
Correct.
you
That's
don't
what.
get those buttons of this size actually, because the stomach is so small. In older children, it becomes easier. For such a small child, you don't get the tubes only, so small tubes.
The very
Correct.
effort that a baby may make in during the swallow may be inadequate, and we have to prompt and give sensory stim and see that she is making a stronger effort and more aware swallow also. Because most of my cases, I feel they improve with better prompting and more kind of awareness. So we don't know the condition of the baby, and we'll have to figure that she has to make a much better swallow. How do we achieve that? That is a challenge there. Do we do some sensory stim? Do we make some tactile stim? Do we give a wet wipe, warm wipe, and then make the swallow a stronger swallow? That's a general theme for us.
Okay. And thickening of feed in this age, what do you do? How do you thicken the feeds?
I think the people who are doing this routinely are, I think, more an expert on how they really thicken the milk or any type of formula foods they're using. But since I'm not a routine guy, I'm not able to give a very specific input here. Yeah, I work with adults more than neonates.
Sir, we are using those pre-cooked rice powders which come as in tins.
Nestum.
But the Nestum, that is only after 3 months we are using. The baby has to be at least 3 months for that. Before that, actually, it's a real big issue.
We have with us. Yeah, tell me, Gautam.
Yeah, we generally add rice, corn, or potato starch. I mean, around 1 tablespoon per ounce. But
okay,
yeah.
Even in
and
this
in
age,
this case,
no
what you showed, the other thing is people sometimes stop milk considering it to be a food allergy and all, milk allergy. But this is not the presentation of. This is much more radical. Yeah.
Can we use these corn, whether it's a corn or rice?
No, not in this baby. Difficult in this baby.
That's what.
Yeah.
So what do we do before 3 months? Because before 3 months, many times it's a issue like this.
We have with us a very, very senior and respected neonatologist with us, Dr. Arun Mangli. So, Arunda, if you can unmute and give your opinion, please. If you're still around. No, I think he is not there. Okay, so yes, that was a challenge, and still people are stuck up with this child, and we don't know like what to do, and regularly these the swallow therapists are coming and stimulating, and all this thing is happening. We used to get this sodium alginate powder, that used to be used as a thickener, but I don't know, it's no longer available here. and I don't know whether it's available anywhere else in the country. So that used to be a good thickener initially, you know.
Sir, even xanthan gum they say na can be used some, but
I have
that
no
also
idea.
like that's just I really don't know. It's not available in India, but somewhere probably I don't know whether it can be used at this age also. Not much, just read somewhere.
Dr. Gautam Ghosh is also here. Dr. Gautam Da, if you can unmute and say a few words, your opinion. No, I think he's probably left. So I think, is there anything, Dr. Amita, you have anything more to add?
No, I don't think there was. I think there's just one question. Dr. Manglik has given that commercial rice formula used to thicken feeds after 3 months of age.
Yes, yes, yes. That's what we said. No, so we are stuck at
Yeah.
this. So I want his opinion. So he's
Before
not
3
there.
months, before
I
3
think
months, what to do?
That's what. So what do we do now? Arunda, yes, please.
Well, we have very little to offer at this age for the newborn. I mean, as far as thickening of feeds, some people have tried even use those human milk fortifiers, but that doesn't thicken the feed. That just adds to the calories. Okay, that
Yes,
doesn't
yes, yes.
actually thicken the feeds. I mean, by viscosity, as far as viscosity is concerned. So there is very little to offer. I mean, you can just add a little bit of say domperidone or a little bit of ranitidine sometimes might help. I mean, all these are just trial and error sort of a thing. There is nothing documented that you could use this or you could use that. And we can hope
Yes.
and pray that as time passes, maybe the child becomes a bit older and is able to tolerate feeds better. Positioning maybe may help a little bit. Putting the child in a slanting position might help, keeping the head end elevated by about 45 degrees. But again, children tend to slip down from that position. It's very difficult to keep infants permanently in that position. So these are very difficult situations, but yes, most of the time the children grow out of it. This very rare situation when the child doesn't thrive at all and has severe GERD. Those are really very rare situations.
Yeah, I remember in our older Nelson's textbook, we had pictures of children with a post in between the two the legs, where the child used to be like, you know, would not be sliding down, but they've
Exactly.
stopped using that. Yeah, yeah. The current Nelson doesn't have that picture, and they've stopped using that completely.
So what was the presentation once more? I mean, just in this baby?
That's what this child had feeding issues. That's all. This child had respiratory distress, meconium stain, liquor, which all settled down. But then this child could not be fed. So this whenever people would try to feed this child, it will be gargling and not feeding. So there was this swallowing issue that remained. So
so.
even a neurological this thing was done, an MRI was done, which was normal. So, but still, an MRI will only be a anatomical delineation. So there could be something else lying behind that. Dr. Mohan, supposing if this child was an older child, say around 5 years of age, a spastic child with a swallowing issue.
Nothing works.
Yeah. I think an older child is always giving us much more scope to work on these variables. And I feel my experience says that the strongest variable is how much effort the child is making in that swallow. It's not just an automatic thing. A certain amount of awareness and effort and prompt improves the swallow. Whereas the feeding issue problems, the children with these problems just don't make that adequate effort, and that prompt changes everything. Not just the viscosity, not just the volume, but the very way he's following the effort he puts and the confidence and the comfort and how the therapists and the parents feed makes a big difference. Of course, the position matters, but I feel some of those variables work well in the older children because they're very easy to work with in older children. Not that in one session we achieve everything, but over a few days they change the whole situation as compared to the newborn baby you're talking about, which is so different. 3 months or 2 months that you're talking about. An older child will be always an easy case for us.
So oral and mucal stimulation you are doing, like some techniques you can suggest?
Let's say you do a wet wipe, a hot wipe or a cold wipe with a pressure, like then the muscles work better, and then you prompt, and then you tap, and then there's a chin tap, and then the volume variables and viscosity variables also help, and then the child swallows better. And once the confidence is improved, the child gets to feed better, and even the articulation changes, lingual movements during speech changes, because most of these children have concomitant speech problems. They tend not to develop good speech if they have a lot of NSU history or some other type of swallowing issues. They have, both will improve. Once the feeding changes, then they start eating better. They don't hold food. They start feeding better, and their articulation therapy also improves, and we see change in both.
Dr. Gautam Ghosh has a question: diagnostic clue, feeding problem, voice problem, failure to thrive, neuro-challenged child, then decide on investigation. And he has asked, I think, Dr. Gautam Ray to comment. In practice,
You
clues to
cannot ask
consider-
me all the questions. You answer this yourself.
In
No,
practice,
swallowing disorders in infancy is the question that has been asked to you.
in practice, he has asked clues to consider aspiration pneumonia. What are the clues to consider aspiration pneumonias in practice?
In a
I
1 month
think that
old,
was discussed now. Yeah. No. To suggest consider aspiration pneumonia, I think Dr. Shilpa has dealt with it extensively in her talk, no, about what are the clues to think of aspiration pneumonia, the age, the manifestations, the symptoms, the investigations, and all that. Okay, Dr. Ray, another thing I just wanted to find out that how do you diagnose this swallowing disorder in an older child? So what do you do? Do you do a fluoroscopy? Do you clinically, many people sort of listen on the neck with a stethoscope to hear a click when the child is swallowing? So something like that. Is it reported? Is it published? So how do you like actually diagnose a swallowing issue so how do you differentiate this swallowing issue from a gastroesophageal reflux disease? And the second point that I was thinking is, how do you differentiate a GER affected child with having a heartburn from a, say, eosinophilic esophagitis? So how do you differentiate these two?
okay, so I'll answer your second question first because that is much easier. So GRD or GER in older children is much more common these days because of our lifestyle changes, because of the increased incidence of obesity and all. So when we clinically suspect it in beyond infancy, so we can give a trial of, though there is no data in children, we can give a trial of PPI, 4 to 8 week trial of PPI. And if it resolves, then retrospectively, our diagnosis of GERD is confirmed and we taper it and stop it. If it doesn't, then we will have to investigate it. What we spoke of earlier, if we suspect esophageal, if we suspect mechanical causes, then we do a barium. If we suspect an achalasia, etc., disorders of esophageal, this thing, but all those are rare. So coming to your direct question, eosinophilic GI disease is much rarer than a GERD. Eosinophilic GI disease is a disease of the affluent society. So it is much more common in the Western population than in India. So we read about it more often in the textbooks and when we go to conferences, but it is not so common in India. Having said that, even if we suspect, the symptoms are similar. So an initial treatment of eosinophilic GI disease is also a 8-week trial of PPI. And if it doesn't improve, Then we do an endoscopy and take biopsies. And your first question was swallowing disorders.
Yeah, so
So-
swallowing disorders and gastroesophageal reflux, how do you differentiate? So whether this child is aspirating from above or aspirating from below?
I'm not the correct person to answer this because we do not get much of swallowing disorders.
Swallowing
Maybe
issues.
somebody, maybe Dr. Mohan or some ENT person can answer.
Yeah, what I
Dr.
think
Mohan,
the
yeah.
reflux thing would be as usual as we discussed.
Sir, if there
Yeah.
is
Swallowing
a,
issue.
sir, if there is a swallowing disorder, the symptoms should be very immediate after the inefficient
Yes.
swallow.
Mm.
Correct.
Once you feed a trial feed, the cough or the discomfort or anything that will come after that is immediate after that.
The swallowing
And,
disorder
Maybe-
coming up, yeah.
Will it be
Sorry.
more common in neurologically impaired or
Yes,
Yeah,
symptom
yeah, yeah.
children only?
definitely their
Not
swallows
in
are
normal,
definitely
yes.
inadequate. So they will be, as soon as you give the input, there will be a reaction. That is why you can say that there is a swallowing.
I think history-wise, it will be quite evident, isn't it?
right.
Yeah.
And Dr. Ray, do you have any experience regarding impedance study versus pH study?
No, what we typically use is a combination of both.
Okay.
So what
yes.
we do is a pH MII, so multiluminal impedance. So I think that's a very specialized subject. Let us keep that apart because
No, but is
even
it
in-
done in our city?
Yeah, yeah.
You have,
yeah,
okay,
yeah,
fine,
yeah.
fine, fine.
yeah.
Great, great. And
And Dr.
obesity and
Bhupesh,
sleep
yeah.
disordered breathing, can they cause aspirations?
Absolutely.
Salivary, especially salivary aspirations, chronic salivary aspirations can.
In fact, the only intervention which has a long-term benefit in decreasing GERD is weight loss. PPI and all is all temporary, it recurs. Weight loss is the only thing which has shown to give a permanent result.
So Dr. Alokpal has asked how to prevent swallowing disorders. So I think he has answered obesity is one of the preventable, like can prevent. Anything else, Dr. Shilpa?
I think obesity has more with GERD, not
Yeah,
with swallowing
yeah,
dysfunction.
swallowing.
Hmm.
Because I don't think obesity has any relation with swallowing dysfunction.
Yeah. Prevention of swallowing disorders is one of the questions.
Yeah, if they had a swallowing dysfunction, they wouldn't become obese.
Yes.
Yes, very true.
Urology. Okay. Yeah.
Okay. So if
Any
there are
more
no
questions?
further questions, yes. Hand over the podium to Dr. Amita.
Thank you very much, all of you, for a very enlightening question and answer session and discussion. Thank you to all the attendees for sparing your time in these busy days. And any more questions? If not, I think we should wrap it up. We can wrap it up. Thank you, Dr. Shilpa, Dr.
Thank
Mohan.
you. Thank you.
Thank you very much.
Thank you, Gautam.
Thank you.
All of the
Thank
thank
you. Thank you.
Bye.
Thank you.
Thank you. Good night.
Good night.